Bigby.
Thanks very much, Carolyn, and thank you for inviting me to be here. When Carolyn asked me to speak today, she said, well, I want you to speak from the perspective of your role as Secretary of Health and Human Services for the Commonwealth of Massachusetts, and I'm very proud to be able to do that. Massachusetts is a very special place. You've already heard from Don Berwick and Lucian Leap, and Jim Conway is a big name in patient safety there. So being the Secretary of Health had advantages and challenges being in a state like Massachusetts. I'll also just say that in our discussion so far this morning, I've heard people talk about the tension between regulation, which is another way to interpret policy, Carolyn, and the need for systems to really drive these changes and improvements. And I don't think it's an either-or proposition. We need both, and I have some examples of why I think that's the case. As I said, Massachusetts is a very special place. This is the 15th anniversary of To Err is Human, but unfortunately this is also the 20-year anniversary of the death of Betsy Lehman, who was a Boston Globe reporter who died from a massive overdose from chemotherapy, where many systems failed and caused that error. Massachusetts created the Betsy Lehman Center for Patient Center and the Prevention of Medical Error in tribute to her, and so there is that sense that this is a very important issue. In Massachusetts, as in most states, the Department of Public Health has the responsibility for monitoring the quality of care, which includes patient safety, and I resonated with Don's comment that separating these things is very difficult. The Massachusetts State Legislature, when they passed the landmark healthcare reform bill in 2006, did pay attention to quality of care. They created the Healthcare Quality and Cost Council, which, even though most people were interested in the cost side of that council, set out some mandates for that council setting an agenda for quality. And I think that that was a very important part of that bill. They also increased Medicaid payments to hospitals to the tune of almost $80 million. But it was tied to them demonstrating some improvements in quality of care for Medicaid populations who overrepresent minority populations, and therefore it was a disparities issue. The state legislature also passed, subsequent to that health reform law, a bill requiring all hospitals to implement computerized order entry. I believe it was by this year, 2015. And so the legislature is not shy at directing hospitals and systems to do things that they think would improve quality. Part of what happened in Massachusetts, I think, illustrates the potential for having government involved in setting agendas and reporting. This issue of transparency was part of the Healthcare Quality and Cost Council's agenda to create a consumer site that demonstrated both quality and the cost of care. That was a challenge to do because of the need to make sure that the reports were things that consumers could understand and that they were relevant and up to date. And a lot of the data we used came from CMS, from Leapfrog, and other places, because our intention was to use claims data to create those, and those took time. But I will say that we learned from that initiative that institutions were motivated to try to do better, to make sure that they had the highest rankings on those reports. The other thing the Department of Public Health did is to require hospitals to report hospital-acquired infections. And initially, there was a lot of pushback on that, but by standardizing the way those were defined and the way that they were reported, it actually engaged the hospital community in a way they hadn't been done before. The initial reaction was, well, line infections, we can't prevent those. Those are part and parcel of the process. There's no way we can get those down lower. Well, in fact, as hospitals worked on this, they learned that it was possible to decrease those events, and in fact, several institutions got down to 0. And by having hospitals all participating toward a common goal that was set by the council, it created the opportunity for learning environments, shared lessons learned, and for opportunities for some of the best institutions in the state to learn from ones that hadn't been deemed such high quality. And I think that that helped to really drive down that particular event. It's difficult, though, when you're focused on only one event. And so one of the things that the Healthcare Quality and Cost Council did is say, well, where is this patient safety movement? Where should it be occurring? Hospitals are not the only place where individuals get their care. Could I have one slide. Thank you. Any of you who are familiar with Carr White recognize the concept of this ecology of medical care. And what it shows you, back in 1961, Dr. White did an analysis, an epidemiologic study. Where do people get their health care? And he started with 1,000 people who were adults and did an epidemiologic analysis. And what his point was that if you take 1,000 people in any given month, only one adult per 1,000 would go to a university medical center per month. But that's where all the effort and money goes. There were some investigators who redid Dr. White's study in 1996, which you see on the other side of the slide. And there are more places where people get their care, but 0.7 are hospitalized in an academic medical center in 1996. And I would say that 1996 is quite a while ago, but with the changes that we're seeing in the healthcare system, the different parts of the system that are participating in people's care has probably expanded, especially as we're redefining what systems of care are. And so one of the things the Healthcare Quality and Cost Council did was set out to develop a framework for patient safety that was usable across the entire system, including physician offices, physical therapy practices, dialysis centers. And I left before that initiative was finished, but I think that that concept, every place needs a patient safety lens, is the only way we'll get to achieving a culture of safety, especially in this day and age where there's some finger pointing going on. Well, this readmission isn't my fault. The hospital can't do anything. It's the folks outside of the system. So that's one thing. The last thing I'll just focus on, because I think I'm over my 3 minutes, is that the initiative to increase hospital rates in the Medicaid system was tied to improving racial and ethnic disparities, or eliminating them, not improving them. What we found is that of the 60 hospitals in Massachusetts, there were only a handful who were seeing the majority of not only Medicaid covered people, but also the majority of racial and ethnic minority groups. There's been a lot of conversation, I'm sure Dr. Calhoun has been part of this, about this notion that these hospitals with high concentrations of vulnerable populations need to deliver the same quality of care as others. I think they should, but we also need to invest the resources in making sure that that happens.